Be sure to consult the accompanying monograph for additional information and for directions for obtaining CME credit.
The newer medicines have been a tremendous advance, but we still have to face the fact that some patients are on the older medicine still, and some patients on the newer medications still will have clinically significant EPS. We can't forget that even the newer medications are all dopamine blockers, and any dopamine blocker can, on occasion, cause EPS.
But right now, there are a few million people who are on these typical antipsychotics, and they're at risk for these long-term movement disorders. And not only are they at risk, it's going to occur in a certain significant percentage of them. And of those people, a certain small percentage, luckily, are going to have it really badly to the point where it causes them major problems.
The jaw starts tightening and going sideways. A little while ago I was fine, but now it's starting to leave again.
Does it hurt?
My back right now hurts, and the jaw and the whole neck starts hurting.
This is a man who came in complaining of involuntary muscle spasms. Look at the camera. He was not a psychiatric patient. After extensive questioning, initially during which he had denied taking any medicine whatsoever, he admitted that he took a medicine, but didn't know what it was, and he had taken it from his girlfriend, assuming it would help actually his low back pain. Are you in pain
my back,
right now?
Yeah, my back.
Let me see your back.
Back spasms. Back starts twisting, like with the jaw, same movement.
He was having recurrent spasms, and the spells would last about 20, 30 minutes at a time. Now, right now in your face, are you...
I'm frowning because I can't help it.
You're smiling because you can't
I'm
help it?
frowning because I'm frowning, and my speech is leaving me again.
Okay.
That's what's happening now.
Huh. And how longer is each episode lasting?
It's been about a half hour. I was fine.
Yeah.
And now it's starting to come back again.
Okay. It's unusual to have a generalized acute dystonic reaction. You want to lie down? That's okay. Most dystonic reactions are from the neck and above, and they usually involve the jaw, the tongue, the head turned to one side. Can you move your leg? Can you bend it at the knee?
No.
You can't bend it.
Not yet.
But his dystonic reaction involved his spinal musculature, his leg, and interestingly was asymmetric. That's one of the many things about acute dystonia we don't understand. Since your brain is presumably symmetric, why should this sometimes involve one part and not the other? And sometimes it may jump from one side to the other side. Why should it spare one place and not the other? Here he's trying to walk, and you can see the severe torticollis. Okay, now turn around, look at me. Is your neck twisted?
Mm-hmm.
Just stay like that, just stay right there. Look at his tongue. That's involuntary that his tongue is stuck out.
I twist it back.
Can you overcome it if you take your hand and push on your chin? Are you asking him at this point whether he has what we call a geste antagoniste? Patients with dystonia frequently are able to overcome the dystonia just with mild touching. They're not really pushing their heads over.
Oh, hey, they heard me talking a lot. This is great.
In the emergency rooms of the medical hospitals, it's the nurses who see most of these things, and they're easily recognized. I think it's when you get a house officer, typically non-psychiatric house officer, who gives drugs like Compazine or Reglan, who doesn't know what these are, I think they may get confused, especially in psychiatric patients, with psychogenic disorders. So you see a patient who comes in who's just received Haldol, and their eyes are up like this, and you talk to them, and as they're talking to you, their eyes come down, and then they drift back up again, and they look like this. If you've never seen that before and hadn't read about it, the first thought, I think, has got to be that this is part of their psychosis. in which case, of course, you may be tempted to treat it with more drug that caused it in the first place. So I think the main differential there is psychogenic.
Now, usually you start antipsychotics under emergency or duress situations. So you don't know the patient doesn't know you, and then 24 hours later, the patient gets a muscle spasm or some kind of dystonic phenomenon. Because acute dystonia tends to come and go, it is a waxing and waning thing. The chances are good that you as the doctor or you as the clinician will not actually see the dystonia. So you have to rely on the history of and the patient is out of it, the patient's psychotic, so you have to rely on a very strange history often, or a history from a relative saying that some muscle spasm happened or some weird twisting happened.
Try to open your mouth. Can you open it more than that?
No.
And does that hurt you?
Yeah.
This disorder usually involves the neck and above. So the jaw might be clenched or the tongue might be protruded past the teeth. And these spasms may be painful, and they're presumed to be major causes for drug noncompliance. Okay? Patient takes the drug, instead of getting better, they feel worse. So they're not going to take the drug, they're not going to come back.
And acute dystonic reactions can occur with atypicals. They're much less likely to. The frequency of occurrence is proportional to their EPS liability. So that as we go along the spectrum of atypical, from going from, say, the least atypical of the atypicals to the most atypical of the atypicals, you will have some dystonic reactions with risperidone. Not as frequently as with haloperidol, but you'll still have some. Then you will have markedly fewer dystonic reactions with olanzapine, although rarely you will get a dystonic reactions, although it's very rare with olanzapine. And I've never seen a dystonic reaction with quetiapine or Seroquel, and I've never seen a dystonic reaction with clozapine. So I would assume that dystonic reactions can occur with all of the atypicals, but they're going to occur in relative frequency from their EPS liability.
And then in about 2-3 minutes, you'll be all better. Okay?
Okay.
Okay. Try not to jump it. It doesn't hurt much to go in.
So they'll have a flurry of episodes of these things until they're given intravenous diphenhydramine or intravenous benztropine or diazepam, and they go away within a few minutes of getting the drug.
And you feel normal?
Not all the way.
And they're virtually 100% curable with these drugs.
9, 10.
And in what way are you not normal?
I still feel pain in my neck. That's it.
Okay, but
Like
that's
it's
it.
like it's really stiff.
So he was treated with Benadryl, diphenhydramine,
It's not there.
and it went away. And he got put on Benadryl for a few days, and it never came back.
Can you open your mouth? Close it again.
Can you tell me what you're experiencing right now?
I'm anxious. I can stop my legs if I concentrate.
Can you describe, do you feel any uncomfortable sensation in your legs?
It's only uncomfortable, it's not painful.
It's uncomfortable.
Yes.
Can you use any descriptive terms for people, who are looking at this? Do you feel restless?
Yes, I feel restless.
Do you get relief by moving around?
Yes.
And when did this start?
When I started the Haldol,
Okay. And it's been getting better since the Haldol's been decreased, is that correct?
absolutely.
Okay.